Okay. Okay, good evening, everyone. Welcome to the Alexandria Public Library. You know where I came from now. Tonight, we have representatives from the Alexandria's Health, Police, and Fire Departments. They will discuss mental health among public workers and first responders since the beginning of the pandemic in 2020. We have three panelists here tonight, and I'm going to let them begin by introducing themselves. And we will then open up for questions throughout, and they will give a little bit start a little bit about where they are in the process of the of our experiences now that we are all doing together right now. So go ahead. But first, Corey, or not Corey, Natalie.
Sure. Thanks for having us here tonight. So I am Natalie Talis. I am the Population Health Manager for the Alexandria Health Department. I also serve as our Public Information Officer. So in those two roles throughout COVID, my job is basically to figure out where the health inequities are in our community around COVID, and then work with residents and community partners to communicate guidance, to help explain what's going on, do outreach in the community, and make sure that we're actually addressing some of those systemic issues in our community as well. So thanks for having me. Brian?
Hi, I'm Brian Hircik. I am the Deputy Chief that's responsible for medical services within the fire department. I oversee our EMS section as well as our community paramedic group. And I have been with the department for a little more than 25 years and got involved pretty quickly with the COVID response because EMS is very well connected nationally. And as some of my counterparts in the Seattle area were starting to receive patients, I was lucky enough to share some of that information. So got involved in that pretty quickly in helping establish what kind of PPE we needed, as well as make connections throughout the city to set up the EOC and work within that area.
Good evening, everyone. My name is Courtney Ballantine. I'm a captain with the Alexandria Police Department. My role at the time when the pandemic kicked off was the public information officer for the police department. So I was responsible for ensuring adequate and accurate information going out to the public about our procedures, policies that were constantly changing, and just making sure that the message was being reached to any and everyone. Currently, my role is the Community Engagement Division Commander. So I'm responsible for overseeing our community outreach, community cookouts that you've possibly seen throughout the city this past year or summer, and also just ultimately ensuring that we are engaged with the community, helping Natalie, helping Brian to make sure people are safe and they have all the information necessary. Thank you for having me.
Thank you for being here. We do have open questions for anybody who wants to bring anything in. But first, I'd like to have let's have a discussion about the very beginning, March 2020. At the beginning of the pandemic, we were all on the same page. We've gone a lot further since then, but what was the initial, how was the initial response? How did you set up your plan of action? And how did we get to the point where we felt like that we were comfortable handling the information and the progress as the disease went through the community in the beginning?
Sure. So I'll start and then turn it over to my colleagues here. I don't think I could say that we're ever going to be in a place where we're comfortable with how information was getting out and how much we know about COVID really, even now. But first, I want to note that even though we only had our first case of COVID in Alexandria in March, the health department was actually monitoring the spread of COVID since like December of 2019, when there was first starting to be cases around the world. And so we actually started way back in December in terms of monitoring this disease, looking at the trends. And at that point, you know, we didn't know what was going to happen. Obviously, we didn't know if it was just going to kind of resolve and go away, or if it was going to become a bigger thing. And of course, we couldn't have predicted that it would be like what it is right now. And so really those first few months, that December, January, we were just monitoring. But then as February happened, we started to see more and more cases very, very quickly. That made it very, very real for us. And we started ramping up very quickly in our operations. And so what that meant for us is that people in their normal jobs got turned into different jobs. So you would have people in different divisions now focusing on these other topic areas. So right after we had our first case in March in Alexandria, for example, we had our nurses stop doing some of their clinical services and actually become case investigators and contact tracers to call people who were ill to figure out where they had been, right? We started pulling people from various divisions to do these really necessary tasks, because it's not like we could just hire a bunch more people to help us. And so really we had to completely shift internally our operations in terms of who could help with this work. So that was a lot of change in a very, very quick period of time. People learning brand new jobs, people taking on new skill sets, all in a time of a lot of confusion and a lot of fear, right? Of not knowing what was going on. I know for me in my role, trying to do, which really my day job is actually not communications. That's not part of my job description, but I became our communications lead because we just needed someone to fill in and do that. And that's what we all did. We all filled in and did things. And trying to explain to the public how to protect themselves when we were getting new information from the CDC and the state every day, maybe sometimes multiple times a day, sometimes that contradicted what we heard the day before. It was an incredibly challenging job, because we obviously, as all of us public servants, you know, we work for our residents, and we want to do our best to make sure that we're providing them that support that they need to make those best decisions. But if we're not confident providing that information, or if things are changing, it makes our job so difficult. And especially, again, those first few months were very challenging in terms of things changing so quickly. We were often working 7 days a week, 12 to 16 hours a day, trying to get things right. And yet, even through all that hard work, it still didn't feel like enough. Right? It still never felt like we could do enough. But again, we had limited staff capacity to respond to something like this. You know, public health has been chronically underfunded for decades, even notwithstanding a pandemic. And so, you know, to add on this intense layer of additional work onto all of us, it was a tremendous amount of strain for our staff. And I think that's something that both Courtney and Brian can relate to, of how do you deal with things when suddenly you're getting a ton more thrown at you, a lot of confusion, a lot of fear of dealing with some of these new challenges as well. And, you know, you're trying to protect yourself and your staff, but, you know, you're also trying to protect residents. And so our jobs are not remote jobs, right? We're either in the office or we're in the field doing things. And so we had that additional layer on it as well, of how do we keep ourselves safe while trying to keep the public safe. And I'd love to turn it over to Brian and then Courtney about that too.
Thanks, Natalie. Yeah, for us, it was even prior to getting patients into Alexandria, we were also focusing on, you know, how do we educate our staff? We have 300 first responders just in the fire department. and everybody's at minimum an EMT. Within that 300, there's about 70 to 75 paramedics that we have. And they became very acutely aware that we're going to start seeing these patients, and we're going to have them in the back of an ambulance with a very closed in space, in close contact with them, in their face quite often. And we knew that they were going to have respiratory problems, of which we hadn't identified yet. Remember early on, the death rate looked like it was incredibly high. So we had some first responders that were very nervous about when they interacted with a patient. What is that going to do for them, as well as what are they going to bring home to their family? So that was, we had to focus a lot of attention on how do we educate our folks, and also how do we keep them safe? What PPE is effective? And we were getting that information from the CDC and through Natalie's group. Early on, we connected very quickly with then Dr. Herring and Dr. Gaddy. And at one point, I had joked with them and said, I can't go to bed until I say goodnight to you guys, because it was a daily and sometimes a 3 or 4 time a day conversation, because information was changing, or there was information on what PPE was going to be back ordered. How do we keep it effective, and can we reuse it? All of these guidelines were constantly being thought of. And then once we started realizing that there is effective PPE, really quick, there was a shortage of it, because everybody went out and bought. There was massive amounts of hoarding for hospitals, and then it seemed like the larger healthcare systems were getting larger orders. So smaller systems, including EMS agencies nationwide, were kind of getting left behind. So we were fortunate in the city that we had a lot of H1N1 leftovers. So we were actually pretty set with our N100s and N95s for at least the first about 6 months is what we estimated. And then we started making some contacts regionally and then statewide on how can we get EMS agencies throughout able to buy in bulk. And we used our regional EMS councils for that through the Office of EMS, and we were able to start securing some things that way. But our folks were just acutely aware of, they knew they were going to be exposed, and then how do they maintain being able to work and keep their families healthy. So we were constantly relaying that information, as well as we put some things into place that were kind of unheard of. One, I started with the fire department as a paramedic, and never thought, I'll be working from home one day. But we separated our chief officers, our senior officers, into 2 teams, so that we didn't have everybody there all the time exposing one another and everything else. So we ended up coming up with an A and a B team. And then we would work in the office for 1 week, and then we would work from home the next week, so that everybody was still getting their job done, but we weren't cross-contaminating, so to speak, with one another. And then we ended up having to do that with our firehouses as well. Our folks come to work and they work a 24-hour shift. So you work very closely with your individuals. You're sleeping sometimes in the same bunk rooms as your coworkers. So we ended up having to focus in on which stations could work with other stations, and making sure that we weren't just, if we did get a case, or when we did get a case, we didn't expose the entire 300 providers in the department, because we needed to make sure our ambulances and our trucks and engine companies stayed on the road for significant emergencies, as well as taking care of patients and those types of things. So we had to put a lot of changes into place as far as how we staff things. And particularly as we started to see some of those cases get pop up and make our way into the station, we started looking at, how can we more effectively clean the stations? How can we keep people from bringing things back to the firehouse? So we ended up having to come up with some new decontamination procedures. And we were able to find some equipment that actually was on our wish list for about 5 years earlier. Because now it was such a demand, we were able to get aerosolized cleaners and those types of things into each of the firehouses so that we could clean our sleeping quarters as well as the back of the ambulances whenever we had somebody that was a suspected case. So going on to our, as we started to get into expectations of when we responded, a lot of the things that I had worked with Natalie's group with was identifying when we did have cases in the city, could they share that information with us? You know, we're all very familiar with HIPAA and making sure that we're not sharing any information about people's medical history. But it became a fine line between, do we let first responders go into a situation where we know that somebody has or has been exposed to the coronavirus, which we still didn't have a grasp on yet, or do we give them a warning so that they can go ahead and put their PPE on and those types of things. So we had to put some questions into place, even starting with the 911 call centers, so that we could get some information, and that way our folks weren't going in blind. Pre-COVID, you know, if you called 911, you would get somewhere between 2 and 6 providers to take care of a single patient, depending on the severity. And everybody would rush to the patient's side. We would bring all of our equipment in, and immediately we would take over your house or whatever it was, wherever we found the patient, and we just had everything with us. Shortly into this, we realized that, hey, we need to limit the amount of people that are being exposed. So we would send 1 or 2 teammates in and then keep everybody outside ready to put the PPE on if needed. That way we didn't expose multiple providers when we didn't need them. Plus we were also leaving equipment outside until we knew that we needed it, because then we didn't have to decon the entire ambulance or anything if it was a simple thing that we didn't have to worry about. But it slowed us down quite a bit. We're used to being a timed response. It was one of our metrics. How quickly could we get to you from the time somebody called 911? And now it's much more, even today, we still have, when we have somebody that is having a respiratory symptom or those types of things, it's much more of a methodical approach to us, so that we can keep our folks a little bit safer, as well as trying to keep the spread in the community reduced as much as possible. So, and I'll let Courtney talk about their response as well.
Thanks, Brian and Natalie. So I like going last because I can just simply say we did that too. But all kidding aside, I mean, this was one of the biggest challenges I've ever seen. You know, I've been through 9/11, that event and the change that came with that. But this one's something that just we never expected, because you can't see it, you don't know where it is, but it would potentially, it's fatal. So like Brian, and we depended on Natalie and the CDC for information on a regular basis, because we had to immediately stop doing what we were doing, because we feared, the administration as well as every officer feared of catching the COVID. And a lot of it wasn't. So one of the things that we ran into pretty quickly is officers didn't want to come to work because they did not want to put themselves in a position of becoming COVID positive because of bringing it home. So we had to kind of look at how we did scheduling. You know, in the law enforcement world, we laugh because work from home. How in the world would you work from home as a police officer? Just like Brian said, I mean, it's just never been imagined. And this pandemic has opened up so many doors in technology that now allows us to do so much more remotely. We were pretty quick to figure out some ways to limit the amount of staff in the building. Just like Brian did with all the fire departments, they have, I think, 10 or 11 facilities, and we have one. And every employee, which is about 400, one day comes into that building. The next day, we had to limit it down to 20 or 30. So we had to figure out how to make that happen so that they can work, but at the same time, ensure the safety of themselves. And that's just with ourselves, right? So now we had to start thinking, okay, let's think about how we respond to others, just like Brian did with how they methodically would go into a call, leaving things on the outside. Because of our world, there's 90% of the time we can have the person calling 911 for police come outside. So we actually had them come to us outside, where it's a little bit safer because you're in the outdoor environment rather than a closed space, without knowing what's, who's in there, what's in there. We use that to our advantage, being able to do that. We limited the calls for service that we actually responded to. Our staffing levels dipped because we said, well, we need to really limit the amount of people not only are in the building, but driving the cars out in the community, because we just didn't know anything yet, really, how big this thing was going to be. So we were constantly adapting, constantly looking, listening to all the information coming in. As Brian experienced, I think we had it worse a little bit with PPE. They use PPE every day. We don't. We have it, hopefully, somewhere in the trunk of a car, but it's one of those things that if you don't know how to use it, don't have it readily, you're not going to. It's a training thing. So we had to go back to the basics to learn, what is personal protective equipment, PPE. So it's not just gloves, it's not just a mask, it's the entire hazardous materials suit. So imagine having police officers show up to a victim looking like a hazmat. We had to overcome some of these obstacles and through that was through communications, like Natalie's office, my office. We had to tell people what the new expectation was, because it is going to be different, and it's scary. It's scary not only for the person calling 911, but for the officer, because what people don't think about is the officers are human, just like everybody else. Same with Brian, Natalie's office, but in the sense of we have a family, we have kids, we have family members that are immune compromised, because it's everywhere, right? That's very common nowadays. And we're scared that we're going to bring something home. So we had to give all this stuff to the officers so that they can feel comfortable enough to do their job. And so that took time because we didn't have a lot of it. So we had to find it. And that was a challenge in itself because everybody's looking for the same stuff. And then we had to write policy and procedures that were constantly changing, like Brian's were and Natalie's, because the information was constantly changing. And then on top of that, and I know Natalie's going to get into it next, is the vaccine. Like, how in the world do we get our first responders the vaccine? And what do you do if they don't want it? And then how do you get the community to trust it, to know that that's going to be, and it's going to be okay? The police department, even today, is still doing a lot of the same things that we did, that we changed, because honestly, it's better. We're cleaning more, we're socially distancing more. If you're sick, stay home. It's simple stuff. Because before, people would just come to work with a cold. They didn't think anything of it. But now they don't know what it is, so they're going to stay home. And that's a huge piece. And it's okay to stay home. So we had to change the culture. And so a lot of those things are still in place today, to help maintain not only the community, but also the officers. We've created a whole, the city of Alexandria is really good about providing resources to the employees. At the time, we had the EAP program, and they had a lot of COVID help. On top of that, the police department and the fire department and the sheriff's office and DEC have a peer support program to allow officers to turn to each other for help. And if that doesn't, they can go professional. But the point is, we really did, I like to say, circle the wagons to take care of ourselves so that we can help take care of the community. And a lot of that was through our policy changes, getting the equipment to help keep people safe so they can continue to do our job. And as Brian mentioned, these things are constantly reassessed. Natalie would call us 15 times a day to let us know, it's not 10 feet, it's now 7 feet distancing. And now we're at 6. So it's just it's an evolution. It's constantly changing. And this is probably the first time that we're okay. We're good with the constant changing because we've done it so many times. We want that. We want to know what's going on. And I think we're doing a lot of great things now to help keep the officers healthier, safer, but by providing that equipment and training, and which results in keeping the community safer too. And I'm going to turn it back over to Natalie to get us into.
I wanted to bring in a question. We got a question from Lynn and Courtney. You touched on some of this already. She's asked, what are some of the changes made or new initiatives created as a result of the COVID-19 that have resulted in long-term improvements, improved coordination, increased flexibility, et cetera? And I know, Courtney, you touched on some of these and some of the practices y'all are maintaining now, but how about Brian or Natalie?
Sure. So I'll share a few things that, that may have started during COVID at the beginning, but I think are long-term benefits. I mean, one, just the ability to be able to do telehealth visits through our clinic is huge. So previously, if people wanted to sign up for the special supplemental nutrition program for women, infants, and children, it's basically food support for pregnant and new moms. They would have to come into our office and we would talk to them and do all of that in person. But during COVID, the state and the federal government basically allowed us to start doing some of those visits over the phone with people. And that made a huge difference in terms of access for people. So now people don't have to get their kids in the car or on a bus, come over to the health department and be able to do that just for information that we could do over the phone. So that's really huge. We hope we can keep doing that long term for people to have that access to our services that they really need. I think the other few things that I would highlight is, as both Brian and Courtney mentioned, we talked a lot during COVID. I think a lot of us agencies at the city, maybe more than we ever have. We were often communicating so frequently and in such length. And I think also when you have that sort of conversation in really kind of tough, stressful times, you build closer relationships with the people that you work with, both internally in our agency, but also across the city. And additionally, even with our nonprofit partners, there were nonprofits, like the example that I give, senior services are amazing in Alexandria. And there was one point, which I know we'll talk about later in the vaccine rollout, but there's one part of the vaccine rollout where I think she and I were on the phone multiple times a day, every day, to make sure that our seniors had the access to the vaccines that they needed. And so I think having that opportunity to build those closer bonds between all of us and have those relationships, I think is really going to serve us in the long term, because there are so many other things that we all work on together and that we need to work on together, that having that stronger foundation will just make coordination much easier and know how we can work together in that way. And then the other thing that I just want to mention too is there used to be, I don't know if people still say this, there used to be an old saying about public health is that if everything is going well, you'll have never heard of us. You'll never even know that we exist, right? But now people have heard of us for better or worse. And on the one hand, I think some people were surprised. They didn't even know what a health department does, right? Like, what do you guys do at the local health department and all of that? And, in some ways, I think we have a nice opportunity moving forward to do more education in the community about things like that we do on a regular basis, right? Like food safety. Right? How do you make sure that you're not accidentally giving yourself salmonella, things like that. How do you make sure that your kids are safe in a pool and that all of that is taken care of? Or, telling people about their regular childhood immunizations that families need, as well as, how to work on diabetes and hypertension issues and asthma and a lot of other topics. So I think we have something that might really help our community in the long term in knowing, like, who is the health department? What do they do? How can they be supportive? I think really having that can set us up to address some of these long-standing health issues in the city that did not take a break when COVID was happening, right? We still have sexually transmitted infections. We still have all sorts of things that happen that don't go away, but maybe now we have this opportunity that people can learn more about those other health issues and how to access the support that they need.
So, and then to kind of piggyback on some of the things that Natalie was talking about, early on, our 911 call volume plummeted. People were very afraid to go to the hospital. People were very afraid to interact with us. And what we were seeing was that was a relation to, they would see on the news that hospitals are overcrowded and you go to the hospital, you're going to get COVID even if you didn't think you had it, and those types of things. So we started a nurse triage line. We actually used some of the Alexandria or the American Recovery Plan funding to use a nurse triage line. So if the dispatchers in the 911 call center felt like somebody was calling as kind of a worried well, they wanted information on COVID, rather than sending an ambulance out, we would transfer that call to a nurse that would then kind of describe the patient would then describe their symptoms. They would talk about, are you having significant trouble breathing? They would do a couple of quick tests for them. And if appropriate, the nurse would then say, you can stay home, make sure you hydrate, isolate from everybody else, use a separate bathroom, and those types of things. And we would never send an ambulance out to that person. They would be able to, they would get instructions on how to handle it well, and then what to look out for that would result in the need for another 911 thing or another 911 call. So that was a big help for us in identifying those worried well. And then we were following that up with our community paramedic program. We started a community paramedic program about 4 years ago, basically helping repeat falls and some of our frequent 911 callers to help get them to the right resource. Well, through the early part of COVID, we were having them follow up with a phone call 1 or 2 days later to somebody that would get transferred from the nurse triage line. So they were able to kind of see those patients virtually through telemedicine visits or those types of things, because we would get a callback number and reach out to them through telemedicine. And that was a huge benefit, something that we never would have thought about in the fire department for, having our community paramedic reach out to people through telemedicine and just kind of talk about symptoms and those types of things. So that was a huge benefit. And we're actually continuing the nurse triage line and expanding it a little bit more now that our call volume is back up to normal. We're doing some things through collaboration with our medical director and through the Office of EMS to be able to expand that and kind of change our scope of practice a little bit. So that's been a huge benefit. We again, pre-COVID, everything when it came to calling 911 for an ambulance was always based on how quickly do we get there. And the correlation was always, well, the quicker that you get a response, the more likely you are to survive. But in reality, probably 80% of what we do, the patient is going to survive. Because you called 911 for a fractured ankle, didn't mean if you didn't, that meant you were going to die. It just meant that your pain was going to be relieved a little bit earlier, and we could stabilize the fracture and those types of things and get you transported. But now we're doing much more education based on, there are some things that absolutely we've got to be there. Your heart attacks, strokes, cardiac arrests, and those types of things, we've got to be there quickly. But then there are some things that we're getting to the point now where we're going to start doing some things to kind of help educate the public to make them realize that, yeah, we'll be there, but it might be 12 minutes instead of 6 minutes to get there. That way it's safer for our responders. You don't see ambulances going as fast to get to something that's truly not life-threatening. So that's been a huge benefit for us, and that's something that we're going to continue to expand upon. Another thing, I was always, when I was in the back of an ambulance, I was always kind of the guy that everybody would make fun of, because whenever I had somebody that had a cough or a fever, I would always wear a surgical mask, because I felt like, and most of the time when I was in an ambulance, or when I was in the ambulance assigned to one, I had young kids at home and I didn't want to bring that stuff home. So I would always wear a mask, and people would say, oh, it's just the flu. We're all going to get the flu, or, oh, we've already been vaccinated. You'll be fine after a couple of days. Well, now we're seeing that be the norm for our folks. Is any kind of respiratory illness, any kind of complaint, where somebody says they have a fever or they're not feeling well, our folks are popping a surgical masks on themselves. And then if they suspect that it's COVID or something even more aggressive, then they're putting their N95s on and getting more prepared that way. So I'm happy to see our first responders take it more seriously. Because I don't know the actual numbers, but the man hours that we lost because, oh, it was just the flu, and then somebody would call in sick. Well, the fire department is a minimum staffed agency. If we don't, if somebody doesn't show up for their shift, then somebody doesn't get to go home until somebody else volunteers to work an overtime shift. So overtime is time and a half for everybody that's on an operational piece, and that costs the city additional funds. So now we're much more in line with, yes, if you are sick, please stay home. But now folks are taking precautions to, let's make sure that I don't get sick. So we're seeing that. And then, like I had said, we are using the aeroclave system. That's something that we had bought through some of the American Recovery Plan funds. So now it's an aerosolized cleaning device that basically sterilizes everything in about a 15-minute period. So whenever we have somebody that was in the back of an ambulance with a fever or a cough or a respiratory problem, they're going ahead and deconning everything and letting it sit for a couple minutes to dry off. And I think back in the early 90s, there were a couple of colleges that were doing some studies on how many bugs were floating around in the back of an ambulance, how many, MRSA is always a concern, and all of these antibiotic resistant things. Now we're actually seeing our ambulances get more clean than some of the hospitals, because we can close the doors, we can completely aerosolize the area, and everything gets killed and cleaned up. So that has been a big benefit, and our folks really enjoy that because it's an investment on their health as well as the patients that we're tasked with dealing with. And then Natalie had also talked about the collaboration. It's just been amazing talking with folks in DCHS and talking about the mental health resources, particularly for our community paramedic. He's made a tremendous amount of contacts because of the conversations that we've had through a lot of the collaboration. The same goes with regional and statewide committees. On pre-COVID, on a regular basis, I was down in Richmond working with the Office of EMS, usually about once every 2 months. Now I only have to go down there maybe once a quarter. Sometimes it's even less than that. So it's about once every 5 or 6 months. But we're able to do a lot more meetings regionally and statewide through platforms such as Zoom and Microsoft Teams and Google Meets and that kind of stuff. So it's been a big change for us to be able to do so many different things. And I see that continuing for a long time to come.
Brack, I just want to add one more thing to the police department. Before we go on to Natalie's second part. Basically, the police department during this COVID implemented a telephone reporting system restructure. And a lot of that was because we wanted officers to stay at home, and then they can still take police reports over the phone and through their mobile computers, which was never thought of as an option. Now, moving to today, we have done a modification of services that went out probably 2 months ago. And that allows us to do more telephone reporting with officers, not necessarily working from home, but still now at the department. But what that pre-trial did, or pilot program, showed us that this is a great use of staff that would not be out on the street, but we're able to do more through the telephone systems virtually. And a lot of that is because of the technology changes that came from these major companies to figure out how to get their staff back to work safely. So we're now using that same mechanisms to do our jobs better. I just want to leave it at that.
Right. So I think next we're going to talk a little bit about the vaccine phase of this work and how we all kind of dealt with that. I will just want to make a quick note there too, something that Brian said that reminded me. So prior to COVID, I should note, not a lot of people know this, but the Alexandria Health Department is actually part of a state agency, the Virginia Department of Health. So technically, like, I'm a state employee, even though I work on the local level for the Alexandria Health Department. But so what that means is that we kind of have two bosses. We have the state as our boss, and then we have the city as our boss too. But during COVID, we had a lot more connections with other health districts across Virginia, because when you're all going through the same thing and you're all struggling with the same issues, having that support system where I could call someone in, say, Blue Ridge area, right, in Charlottesville, and say, have you guys dealt with this? Have you come up with something on how to address this yet? And be able to share those resources instead of just everyone creating their own thing from scratch was so huge, I think, as a big support for our mental health too, in terms of just being able to lean on people going through the exact same impossible situations, and sometimes even just to rant and share, like, can you believe this is happening? What is the CDC doing? All the way from let's help each other work through this. So that was really big. And when it came to the vaccine rollout, we were left creating a lot of things from scratch. So I don't think a lot of people know this, but basically what happened was, the CDC set out these parameters for who should get vaccinated first, and the state set out those parameters as well for us in terms of the order of who we had to vaccinate people, right? So healthcare providers, older adults were the first. But in terms of how do you actually find those people? How do you get them into a system to contact them when vaccine is available? How do you schedule them for an appointment? How do you keep track of all your vaccines? None of those systems existed. We were not given any handbook. We were not given any blueprint to say, this is how you should do it. This is the way to do that. So it was truly our team at the Alexandria Health Department spending a lot of late nights figuring out a system for how to do that effectively. So we had a lot of contact lists of healthcare providers and contacted them, a lot of email lists for how to reach them. We spent a lot of time figuring out and talking to people like senior serving organizations about how do we get in front of seniors to let them know they're eligible? How do we contact them? How do we work with them on this? Right. So we spent a lot of time creating those things. We actually had this really brilliant staffer who's on to grad school in France, who actually coded a system to schedule appointments. Like, she built a appointment scheduling system that I think could rival the systems of any big healthcare system that wanted to go toe to toe against this system that she just made. And we use that system to schedule, 30,000 different appointments for people. It was truly amazing. But because we were creating all these systems, it was a tremendous amount of pressure, right? How do we get this right? This is so important. This could end the pandemic. If we get this right, if we do this well, COVID could be over, right? And so creating all these new systems, hoping that they work, trial and error, working out the kinks when things didn't go well. It was a lot of that. right? And how do you deal with some of the initial big swell of demand that we had where everyone wanted a vaccine in our community, but not everyone was eligible. And unfortunately, there were some also very difficult times in terms of that demand piece. So up until then, we got mixed feedback from the public. Some people were really glad that we were there to help. Other people told us that we weren't doing anything, we weren't doing enough. And when it came to the vaccine, unfortunately, there were some tough days when we got people calling our call center, accusing us of hoarding vaccine, saving it for our friends and family, doing all sorts of things, skipping people through the line, just pretty nasty accusations. A lot of people would call and say, well, I know the mayor, you should let me in. And it's like, well, that's okay. He's in the back of the line too. So that was kind of hard to deal with in terms of our frontline staff answering those calls, and like, how do you talk to people who are so stressed and so worried? Like the people who are calling us about that, we understand their frustration, right? Like a lot of people who have underlying health conditions that were at really severe risk of COVID, who wanted to get vaccinated, but we just didn't have the supply. It just wasn't coming in fast enough. And so that was incredibly difficult to deal with, that that expectation of the community of, we need all of this done now, and just having that pace. And then of course we had the other problem, which is when supply finally caught up to demand, people weren't interested anymore. We had gotten all the people who wanted to be vaccinated, and then we had all these people who not interested in the vaccine because, we put microchips in it, or because of whatever, because there was live COVID in it. Obviously none of those things are true, but, talking to people about their vaccine concerns is not an overnight fix. It takes a lot of conversation. It takes a lot of support, a lot of non-judgmental, hearing out the concerns and countering them with facts. And we were really lucky at that time that we had gotten some temporary funding from the state and the federal government to be able to hire some contract workers. So we hired bilingual outreach workers. We sent them out into the community. They were doing amazing things. They were knocking on doors. They were hanging outside grocery stores. We even did really awesome things like with our partners at the police department and the fire department and the sheriff's department, as well as ARHA, our public housing agency, where all of us would get together and knock on doors together, especially around like the North Old Town area where we have a lot of public housing. And it was this amazing collaboration between all of our agencies to make sure that people heard that, yes, you can be vaccinated. This is available for you. Here's how we can sign you up. We will book you an appointment on the spot while we are standing here at your doorstep. We really pulled out all the stops to make sure that people could get vaccinated and do that. I think one of the other things that we learned in that process too, is that people have different impressions of how fast or slow government works. Right? Even us internally in government have different ideas about that. And I think there were things pre-COVID that took a significant amount of time to maybe get done or get approved and go through all of that, including, doing innovative communications things that during COVID, because we had that urgency, because we could be saving lives, we did things much faster. Right? We tried new things. We got things done faster. People might have seen there's signs on telephone poles about how to get vaccinated. I don't think that's ever happened. We put out yard signs about getting vaccinated. We sent out multiple all citywide mailers, like every door mailers in 4 languages. We did all this stuff that really hadn't been done before. And we did it as quickly as we could, because everyone was committed to like, yes, we need to quickly get out this information. So I really hope that continues long-term in government as well, of like, we know we can get this done faster now. Now we have evidence that we can do these things quickly and efficiently. How do we carry that into our other work? And so that was a lot of what the vaccine rollout was for us. It was very hectic, but at the same time, our very first vaccine clinic was on Christmas Eve in 2020. Most of our staff was there, and people were crying, right? Like, I was crying. A lot of people were crying because, like, this could be the end of COVID, right? And we were there to help make that happen. It's what we train for. It's what we do a practice flu shot event for every single year, is to train for that. And so getting to be a part of that was probably one of the most humbling things of my life, to be involved with that, to help make that happen. And it's kind of nuts that we're still vaccinating against COVID this long later, and that we're still working to talk to people about the importance of vaccination, and then boosters are going to be this fall, and everything, and it goes on. But we built this enormous vaccine operation, partly with the help of Brian's team, helping to be vaccinators at our clinics, because just health department staff alone, like, we can't do it. So we involved our medical reserve corps, we involved the fire department staff, we involved a lot of people to help fill out those ranks. I think the police department did some shifts in some various staffing, guarding our vaccine supply, which is critical. And so, standing up an enormous operation where we ended up vaccinating tens and tens and tens of thousands of people, residents in our community, was just huge. It came with a lot of stress and a lot of difficult times for us, but ultimately, we're just so grateful to have been able to do that. And I'm gonna turn it over to Brian and Courtney to talk about their experience.
So Natalie kind of hit on one portion that I was going to talk about, is that, as paramedics, we give shots on a pretty regular basis. It's something that, we have medications that we carry, we draw up, and then we administer in the back of an ambulance, whether we're heading to the hospital or whatever it is. And as we were working with the health department to realize that, hey, there's not, 260 nurses that they can just say, hey, we're going to fill out these vaccination clinics. Then, we jumped at the opportunity to be able to say, hey, we can help you with that. Come to find out that in order to provide a vaccination, paramedics at the time, it was not in our scope of practice. So I worked with the Office of EMS, and I belong on one of the more active, it's the Virginia Association of Governmental EMS Administrators, and it's very active with helping lobby things and those types of things. So we approached some groups that helped us push some of the guidance through the governor's office to be able to put some emergency legislation in place that would allow us to participate in vaccine clinics and those types of things. So we were very fortunate because everybody knew that every locality was going to be short of vaccinators. So we were very fortunate to kind of push it through quickly. And then we found out that, okay, yeah, we're good and we can put it in our scope of practice. But in order to do that, you have to go through the same nursing training that everybody else is going to give this medication. So then I had to push it out to all 75 of our paramedics to say, okay, so yeah, we're good, but now I need you to take this online class. And it seemed like it was an online class for the Moderna vaccine versus the Pfizer vaccine. And then you had to make sure that you were educating people on what are side effects on just a vaccination in general. So all of my folks are looking at this going, okay, we already know all of this stuff. I get it, but we still have to do that. So we had about a 30 to 45 day ramp up of us saying, yeah, we got this, we can help out, to, okay, slow your roll and let's make sure that we're educating everybody. And then finally we had gotten our list of providers and our medical director was on board with it. So we worked collaboratively to be able to participate in the vaccination clinic. So, and like Natalie said, I was working on that Christmas Eve. And it was, I think I probably ended up giving about 45 vaccines that day. And there was probably 10 folks that were just crying because they were so happy that it was, and it was a party atmosphere. It really was. Everybody that was there wanted to be there. They were excited to be there. And it signified the beginning that we can beat this thing. So that was a pretty powerful thing. And we had early on, much like we were educating our folks in what COVID was and everything else, then we had to switch our education to, hey, let's make sure that we're vaccinated. And let's make sure that we're talking to the community about the importance of vaccination, because we had a lot of folks that within the fire department even that said, oh, I don't want to get the vaccine. They rushed it too much. Who knows what it's going to be? And we had to do a lot of education on how it was actually created. And we were pulling out all kinds of stops to convince folks to be able to get vaccinated. We still haven't reached 100%. But we are about 88%. And every now and then we still get one or two folks that say, okay, yeah, maybe it's time for me to do it. So that was a big push for us. And then on top of it, it was, we want to be able to help with staffing, but we also had ambulances to cover and we were short staffed as it was. So we didn't get to help as much as we had liked to. But I even, put my gloves and PPE on to be able to help out and provide some vaccinations on weekends and evenings. And it was kind of fun for me to be able to interact with patients again in a fun atmosphere. So it was a big change for us to really dive into true public health and being able to interact. So that was a big benefit, and we've grown tremendous relationships because of that.
So as I said before, we did what they did. No, so basically the police department, I think our biggest challenge was getting our staff vaccinated, and also adapting to the city policies and procedures if you weren't vaccinated, and you couldn't come to work, or you could come to work, and that constantly kept changing, which basically created a constant change in our staffing, scheduling, patrol staffing, how we operated with working from home, various things. And on top of that, so it's the folks that had a previous medical immune deficiency, or whatever you want to call it. We had to kind of figure out what that meant, how that worked. And we did participate in the vaccination locations with security and or just traffic control, because it was an absolute mess, right? And that's okay. We wanted to be there to make sure people were able to come in and get vaccinated. And like Natalie said, we were out in the community, knocking on doors, getting people to understand how the vaccines work. A lot of it was they just, they don't trust the vaccines, or they don't understand and they don't know how to ask the questions, or they don't have the means to get to the places. So we work with all the different city agencies to try to support the communities to the point where we would bring vaccinations to the community. We would do community cookouts during that time to have all those services come to those communities that potentially had less amount of people vaccinated, so that they got vaccinated right outside their door in one of the mobile trucks that the Department of Health and Alexandria Health Department have. So those are awesome things that we were able to participate in, and we continue to learn. And the policies for the city continue to change, even now. But the most important part is we want our folks to be safe, but also we also respect that it's their choice. So yeah, I think that's where we're at right now.
I know we're running up. I think we're ending at 7:30, but I guess maybe the last thing that would be nice to note to people too is that it feels like a lifetime ago that we were talking about this stuff, right? The first cases and like the vaccine effort, but but health concerns don't stop. And now we have monkeypox, which is a real thing in our community. So if you can imagine, our health department staff still dealing with COVID, but also now we're responding to another very serious issue, which is monkeypox in our community. And unfortunately, a lot of those wonderful temporary staff that we had on board, that funding ended. So they've gone away. And so we are much closer back to our pre-COVID levels of staffing while having to respond to two major issues with the threat, the very scary threat of what's in New York with polio too. And so it's very tough because we think about like, how do you recover? You know, we're talking about mental health, like how do you recover from the stress of dealing with COVID? But at the same time, now you have these new things that you have to tackle on at the same time. There's not like a clear end point of when like it's over, right? And so it's going to be a really big challenge for our staff to have to go into these next issues. And you know, we're already ramping up our monkeypox vaccine efforts. So we are doing, in a week, we're doing COVID vaccines, we're doing monkeypox vaccine events, and it's a lot. It's an incredible amount for our staff to take on. And you know, again, we're really grateful that we have partners in the city, but also our nonprofit community, our faith-based community, our business community, and just really active, passionate residents who do a lot in this city. And I think that is just so huge because that's how we do this, right? Like COVID is a public health emergency, but there's no way that just a health department would be able to respond to something that big, right? It takes all of us working together on this stuff, and that gives you a little bit of support in terms of that comfort of how we move forward with some of these really major challenges that are still in our community. So I'm grateful to have the partnership of the folks here, as well as other city agencies and nonprofits, and that residents care about these issues. We have wonderful volunteers in our Medical Reserve Corps. We would not be able to do anything related to COVID without them and their willingness to do this work. And I think that's really just how we move forward in all of this.
So, and Bracken, I know we're wrapping up, but you know, we have to say thank you to Natalie and her group because they have led the way throughout with the city, through the EOC. Like she said, working 14 and 16-hour days sometimes. It was really incredible being able to work with those folks. So, and Natalie has been at the forefront, and she's been in just about every meeting, and doesn't matter the hour, you can see that she was always there and available, providing some guidance. So thank you, Natalie, as well as everybody in the healthcare, in the health department, for helping us all out.
And Brian, I agree 100%. Natalie is amazing, and she was able to lead the charge with providing the information to help keep our folks safe, as well as your folks, Brian. So, you know, we're here to support your mission as well, and all the city agencies' missions, because ultimately you all help keep us safe, and we do the same for you guys. So this has been we'll wrap it up with the idea that this collaboration, this opportunity to work together, like Natalie, you said, has been absolutely amazing, because before I'd have to figure out who to call. Now I know who to call, and we already have that established relationship, and that's going to make this next round of chaos much easier. Plus, we've gone down a lot of these roads that we're getting ready to walk back down, right? So we've done some amazing things that work. Some things could have done better, and guess what? Seems like we might have an opportunity to do them better moving forward. So yeah, it's been an absolute pleasure to continue this stuff.
Well, Natalie, Brian, Courtney, thank you so much for the service that you all have done in the last 2 years and upcoming. I feel much more confident understanding a lot of the details that y'all have provided for us tonight. Thank you again for your service. This everyone out there watching, this is being recorded, so it will be available on the Alexandria Library website, probably sometime late tomorrow. And I will stop the recording now.